Hey guys, Mike with FlightBridgeED. I've been an EMS training officer since 2008, and I don't know how many times I've had to deliver the bad news to someone about an expired certification. That means no work. That's where Piace comes in to save the day. Never be caught off guard again with an expired cert. Go to the App Store for your device and search for Piace, P-I-A-C-E-T, the one-stop application to manage and share all of your certifications. You know you don't want to be that guy or gal, and don't rely on your agency to tell you about your certifications. Go to Piace to manage your own certs and have some peace of mind. Download Piace today.
The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you, coming live from AMTC, here with my good friend Kelly Miller from Air Methods. How you doing, buddy?
Doing great. Had a great conference so far.
Well, we really appreciate you taking the time out of your day. One of the podcasts that we have wanted to do for a while, we did a podcast earlier in the year with Evan, and everybody really enjoyed that podcast. And I was just telling you before we started recording, number one downloaded podcast of the year, which really blows my mind, and it really shows that people have a lot of questions on how to become a flight nurse and flight paramedic, and we really focus it more on the paramedic side. You're a nurse by trade, and you have a real broad experience level. So I thought, we had talked previous about doing this back home. We both are in Kentucky, and just doing it over Skype, or me coming out to your place and doing it. And so we saw each other yesterday, and I thought, why don't we do it here?
Yeah, and it's great, to see the enthusiasm still there for this field of work, and especially in my position where I'm constantly looking for qualified medics, qualified nurses, to see that podcast is getting downloaded and people's trying to figure out how to become a flight medic, a flight nurse. That's very encouraging, and it gives me faith that there's going to be a good pull there every time that we post a position, and that's what we need. We need good, solid people.
So if you had to, we won't make this podcast real long, but if you had to give from why don't you go through really quickly your experience, as a nurse, and how you ended up in the HEMS environment, and then now as a clinical manager.
So my road goes all the way back to childhood. Growing up, my dad was a paramedic. He was a director of EMS service. I grew up around there, lived in the Bay during summers sometimes, learned good, bad there, all kinds of stuff. But it was great. Seeing the helicopters come in, that was the coolest thing when you got to see that happen. Then as I went on, went into nursing. I worked my way through nursing school as an ER tech, learned a lot there. Started out in nursing in ICU, then went into CV ICU. And then about 5 years into that, felt like it was time to make a change. I wanted another challenge, and had someone approach me and said, "Hey, have you thought about flying?" And that's how I got into the field. And from there, that was in 2007. So it's been a long road, and it's been a great job, and I've enjoyed it. Still love it.
So you have a very diverse experience level. You chose the nursing route over EMS, and I think that's a good choice. I think, I get asked that question all the time of should I go the paramedic route or the nurse route. I think definitely going the nurse route opens up more doors. I think the nursing profession is definitely more advanced. Your strength in numbers, the unions, the different associations, I think you guys have it down, and I think that you definitely have more opportunities. What do you think was the biggest asset to becoming a flight nurse in your nursing career? So if we start going down, and we had to go down a list of for these nurses out there that want to become a flight nurse, what do you think is the most important part of your past career that really sets you up for success?
Yeah, well, I'll tell you, probably the good thing to kind of lead into this is that I see many paths be very successful in this job. There's no one path of ICU, CVICU, ER. There's no one path I can tell you that's the way to go, because I've seen all different types of paths be very successful. And I think the same thing with me when I was, especially during my career in CVICU, a lot of things hemodynamically especially really clicked well for me. And that was probably the why and the how things work versus just you do this for this, you do this for that, but understanding how the heart's working, how the hemodynamics are working, things like that. That's what really helped me, because once you get a grasp on that, you can turn that into any field. You can use that in the ER, you can use that in a helicopter, you can use that in the ICU, and that's the key. It's not just memorizing protocols and memorizing pre-orders of, this patient's having this done, I'm going to do ABCD. It's knowing why you're doing ABCD, and that's one of the keys. Is any time that you're doing anything, being that person who wants to know the why. And that's key in this field. You have to know the why, and you can't just be, all right, the cookbook says to do this, I'm going to do this. You need to understand the why in this field, because we're going to give you multiple different paths of how to achieve that. You've got to understand which path's the best. We carry 6 different medicines that can increase your blood pressure. So not every patient needs just dopamine.
Yeah.
You've got to understand the why of why we carry dopamine, Levophed, dobutamine, vasopressin, on down the line.
Mm-hmm. Do you feel like you often get the question of, I'm primarily an ER nurse, I'm primarily an ICU nurse. I think from my experience as a clinical educator manager, I got to the point where I really could care less of what their experience was.
Yeah.
And I've tried to talk about this on other podcasts. I wanted to know, number one, how humble they were in the interview process, how they presented themselves, how, if they didn't know an answer to a question we asked, how did they articulate that to us, and are they teachable?
Yeah.
And I think those are such amazing core traits that for an employer to look at. And I think as long as you're trainable and you're hungry to learn, as long as you have a good foundation and you're willing to put the work in, I think that's the key. Now, obviously, I think any experience that we can bring to the table is important, and what you said about your primary experience that you loved was the ICU side, and you love cardiology, and you love balloon pump therapy, and you love all that. And I think that is much different than somebody that was just focused on the ER. I think there's 2 different thought processes there. So how do those 2 thought processes intertwine with the flight environment? If you had to give a ER nurse that advice right now.
The key is to look and say, what are my strengths, and what are my weaknesses? And it's tough sometimes to do that evaluation, but you've got to understand there may be things that you've not been exposed to. We see a lot of applicants now who come into our field, get in the back of a helicopter, and when they're on orientation, that's the first time they touch a pediatric patient. Because you have many ERs now not doing pediatrics. You go to adult ICUs, you come straight out of school, you go to adult ICU, you may not handle pediatrics. So looking at that and saying, where do I need to improve myself? And even in my experience, I'd had some peds experience, but not a lot. So one of the first things I did was I said, all right, I need to improve my pediatric. So I started teaching pediatric courses. I went and took ENPC. I went and took a few just basic courses like that, and then obtained my instructorship to start teaching, to force myself to get better at understanding, those pediatric illnesses and different things that I would be facing, to have a better understanding. And so I think it's very important that you take a really good look in the mirror and say, what are my strengths or what are my weaknesses? But you hit on it, a minute ago, that character traits are very much more important in this field than experience, because we can teach you a lot about how to take care of a patient having a massive stroke, how to take care of a patient having massive hemorrhage, how to resuscitate a trauma patient. We can teach you that stuff. The character traits are very key in this job. You have to be very self-disciplined, You have to be a little bit of an adrenaline junkie. You have to be ready to deal with the fact that you're going to come in, and instead of having a 12-hour shift where you're on your feet busy, someone constantly in front of you, you're going to have a lot of downtime, and you got to take advantage and make the most of that downtime. A big issue in our environment is complacency.
Yeah.
Because there's so much downtime, and you have to have the character traits to resist that and make the most of that downtime. If you use that downtime on Facebook versus in review courses and learning things and courses like FlightBridgeED provides and so forth, if you're not looking at that stuff, reading studies, then you're going to become weak in this field and you're going to slack off. And we see that happen a lot. So the character traits is very, very important. I've seen 20-year nurses come in and be great and be perfect. And then I've seen 5-year nurses that are hungry, that are enthusiastic, come in and blow away someone with 3 times the experience. So it's not all about years of experience. It's more about what you're doing with that experience, the character traits you have. Are you continuing to grow, or have you plateaued off and you've been plateaued off for a while? And do you have those traits to where we look at you and say, they're at risk for complacency. When we put them in 3 years into this game, they're going to be sitting there and they're going to be the one on Facebook versus the one studying, trying to say, what's the next thing I've got to learn? Because it's an environment that is constantly changing, like all medicine.
Yeah, I think you made some really solid points. One of the points that I do want to bring up is on the previous podcast I did with Evan. I think one of the things I said, and it may have come across wrong, as I said that a lot of times I would take that 3 or 4 year paramedic over a 20-year paramedic, and I didn't mean that in a negative way, but here's the problem with that, is that you may have 1 or 2 out of 10 20-year paramedics that haven't become complacent, that haven't gone into that stagnant state, whereas a 3 or 4 year medic, it's just the times, right? FOMED is here. FOMED wasn't here when I became a paramedic. You have just, again, 1 or 2 out of 10, and I'm just throwing out a number that is eager, that stays up on things, that is teachable. And the older we become, the more chiseled we become, the less apt we are to want to change. And medicine is all about change. So I've had emails, lots of emails, and that is one of the things that has been pointed out. And they've been nice emails, just pointing out and saying, hey, I'm a 25 year, I had a 30 year paramedic that wants to become a flight paramedic, and I am eager to learn. And so I just want to point that out, that it's not that we're saying that a 20-year clinician is not set for success. It's that time gets in the way, and it's real easy to get left behind. And if you're not motivated, if you don't know the tools, if you're not up on technology, if you don't know what a podcast is, if you don't know how to access literature, like a lot of us older, I'm always behind on technology. But you ask these younger millennials, as we call them, they will blow us away. And so that's where I have seen exactly what you said, that 3 or 4 year that will come in and blow away a 20-year clinician because of just the era that we're in. So I don't want any 20, 30-year nurse to think that we're saying that that's bad.
No.
If you are hungry, you're hungry, and that's fine. But what we're saying is that is just a pattern that we have both seen.
Yeah, because as you mentioned, the accessibility to that information, that education, is now easier than ever. When I first started, I remember the first hemodynamic course I had to drive 3.5 hours, pay $200, and go sit through it. I can get that same information now on YouTube.
Yeah.
And really can, and great, and get multiple sources of it. And there's no excuse. And that's one of the questions I'll ask when I interview somebody is, what's the last paper you reviewed? What's the last study you looked at? And you'll have both sides. You'll have that 20-year person, you may have that 3-year person, can't tell you anything.
Yeah.
And that shows me they're not hungry. Because as you mentioned, you can look on Twitter, you can look on anywhere, just Google search, look on YouTube. There's stuff out there all the time. You don't have to subscribe to, the days of having to subscribe to a $100 journal
right.
annually to get that information are gone.
Yeah, there's so much free education out there.
And there's no excuse for not for not learning and continuing to raise that bar for yourself. And so that's one of the things we look for. And like you said, you'll have the 20-year person that's still hungry, that just never has had, their situation has never been to the point that they can fly. Now they have the opportunity and they want to, and that's perfect. If they've stayed hungry, they've educated themselves. But you're right, you see a lot of people who have got to that point. They're a 20-year medic, a 20-year nurse. They have ACLS, PALS, BLS, and maybe a trauma cert. You ask them about the last paper they reviewed, and they can't tell you anything. That speaks a lot. And then you'll have that 3-year nurse who's got her CCRN, who's got 2 or 3 extra advanced certs, who can tell you 3 or 4 different papers they've read in the last 2 months. That's a hungry person. That's an enthusiastic. That's the person that you can put at a base where they're seeing only 2 or 3 patients a day, and they're not going to take that downtime and get complacent on you and be sitting there twiddling on Facebook. They're going to be learning. They'll continue to grow, and they've got the enthusiasm to continue to grow, because in this field, it doesn't stop with orientation. When you get off orientation, and for us, when you go from that 3rd seat to that 2nd seat, you still have a lot of growing to do, and if you flip a switch then and go into a lower gear at that point, you're going to fail, and we watch for that. It doesn't happen that often, but with the wrong person, the wrong character traits, it will happen, and that's something you have to watch for.
Well, and I think we've both seen where you hire an employee and they get started in the orientation process and they're struggling, and this was always my big gauge. If I was precepting somebody and through their evaluations I was saying, hey, you need to work on this piece of equipment, or there's a definite weakness here, sit down with them, show them the equipment, go through the process, and then, I'm not one that's going to hold your hand. At that point, I need you to show me you're going to take the initiative. And if you just come in and sit in the recliner and you watch TV, or you go and go to your bedroom, and you're not out at the aircraft every morning going through that piece of equipment, or pulling the ventilator out, or pulling the IV pump out, and then we get on a flight and you struggle with the same thing, that's a big red flag for me. And so I think that if that's one piece of advice, is you got to continue that hunger. I mean, it's a couple year process before you should be comfortable, and still at that point, right when you think you're comfortable, you're going to get a flight that's going to knock your socks off.
Something totally changes.
Absolutely.
And we go through it all the time. I mean, if you told me when I started my career that every time we RSI'd somebody, we were going to pull out a checklist and go through it, and we weren't going to get assassinated on scene, I would tell you you're crazy. Now, that's the best practice. I'm sold. I swear by it. And you would have to fight me to do anything any different.
Right.
And you're right about the preceptorship. If you sit and you expect your preceptor to tie you down and spoon feed you, you're crazy. It's not going to happen. You've got to be sitting there saying, please, tell me this, and make it easy for them.
Almost
where they can,
nag.
Yeah, where they can just pour it out, and you're taking it in.
Yeah.
These guys have a ton of experience they can give you, but they're not going to beg you to say, hey, let me tell you about this.
Yeah.
So you've got to be a sponge, and that's my lesson to everyone we hire is you've got to come in as a sponge. If you know it, that's fine, but if they say, hey, let me tell you about this, listen to it. Just be a sponge.
Yeah, and I think that goes back to what you said about hiring off personality and being teachable and having that humility to understand. I don't care if you come in and you've flown for another company 10 years. I can tell you from the perspective of Air Methods, and I'll just use, since you're a clinical manager with Air Methods, and that's my previous employer, you go to orientation in Denver, you're going to be retrained how Air Methods wants you to be, and you have to be receptive to those changes, right? I mean, and understand that it's being taught for that reason, for a reason, right? It's all backed by data, it's backed by the clinical dashboard, it's backed by lots of thought, and you have to be teachable. If you had to compare a paramedic and a nurse, and I think that the training is different. When I look reflective for me, I think when I jumped into the HEMS environment, I think looking long term, not being so focused on a task per se, but looking at 10 tasks ahead was probably where I realized really quickly that I was behind. where I have seen precepting nurses. I've seen that having to balance a lot of things at one time with that complete autonomy with you and a partner, and I've seen that be a struggle. So what have you seen, and what advice could you give for that nurse? Maybe that nurse is an ER nurse. I think ER nurses probably have an easier time. Again, I'm not stereotyping, but dealing with a lot of different things, where I see ICU nurses that I've worked with that are so detail-oriented. They're super, super focused on, it's just a different skill set. And I think you have to have both coming into this environment. It's very foreign to come into a pre-hospital environment if you have no pre-hospital experience. You get on a scene flight on a freeway, that's a little overwhelming sometimes, right? Because there's no organization, it's chaos.
Yeah.
Right? And I think a lot of nurses like organization. They like that team environment, and you don't have that team environment. So what could a nurse do to maybe prepare for that?
Well, the best way I tell a lot of the nurses is when you have that patient come back from OR and everything's tangled up, everything's twisted, everything's messed up, that's the environment you're going to be put in every time you load a patient and every time you unload a patient.
That's a good
so
point. Yeah.
you've got to just accept it, and that's tough sometimes because a lot of nurses get tied into having everything organized, and it's great when you can do that. It just doesn't happen in a transport environment a lot of times. So that's tough.
Yeah.
The biggest issue I see in nursing and getting them transitioned over is taking that knowledge and that skill set and putting speed behind it. There's times when we slow down, and there's absolutely times where you have a 45-minute bedside time. I'm okay with it.
Yeah.
That ARDS patient, it's got multiple drips going on, that is really quirky on getting switched over on the vent. You're not going to get a question from me when you spend 45 minutes or an hour at bedside to make sure it's done right. But then you go in on that STEMI patient and you spend 45 minutes switching over nitro and heparin and things like that. I'm going to be saying, why?
Absolutely.
Why? And that's tough sometimes to understand that there's a balance there, and what needs speed and what needs to slow down. And so I think that's the biggest change for nurses is getting that speed in and taking that organized big room environment and cramming it into sometimes a real tiny helicopter. And then it's just you and the medic there. And especially in the ER world, you're used to having a doc there to bounce it off of all the time, bounce this also off of. And we have med control, but in the times that split-second decisions are needed, you can't call med control and wait on them to get back with you. It's you and a partner, and learning to work and bounce stuff off each other, and that autonomy is a learning curve sometimes. And so I think that's a couple of the biggest challenges.
Absolutely, I think, and that's a great point. I think I say this on other podcasts, I say it in our courses. I think the best team, and this isn't knocking docs or dual nurse teams, but I do think the most diverse, strongest teams are paramedic nurse teams. And I think if you should get to where that team is unidentifiable. You and I have flown together.
Yep.
I never felt like anything was difficult. Like we didn't fly a lot together, but when we flew together, we didn't even really have to communicate. And even though maybe in that area, people knew who you were and knew who, if we took our name badges off, nobody should know who the nurse or paramedic is. And that's a hard balance to get to, because especially if you have a paramedic and a nurse that don't know each other, there's always that competition. You don't understand each other's thought processes. You've been trained completely different, and you have to all of a sudden trust this other person, especially if you haven't flown with them. Like when I was afloat and I was floating around and I was at a different base every single shift sometimes. Now, granted, I got to know these people, but they don't know me.
Yeah.
They have to automatically trust if I suggest something that but you also have to be willing to take that question back. Well, why would we do this? And you have to be humble enough. So I think that is always a dynamic that's a huge thing.
Yeah. And that's tough because, especially getting into a CQI process where you're asked a lot of questions about your chart, about your care. Why did you do this? Why did you do that? Besides just from your partner, from your peers, from your medical director, from your manager. And that's tough sometimes to be able to accept that criticism and say, hey, this probably could have been done a little different here. And so I try to prepare people for that, because especially in the nursing world, I mean, I'll tell you, in my career, as I went through nursing for over 5 years in the hospital, never once did I have somebody come to me and say, hey, why did you make this decision a week later when they were reviewing a case? Never had that.
Yeah.
Never had that. EMS, it's most of what I know of, it's hit and miss. You'll have some services that's great with it, some services that never do it. Our program is really aggressive.
Do you want to explain to the listeners what that means for how when you say 100% peer reviewed, what does that mean?
Yeah. So every flight that we do is reviewed first off by a peer. You have, and the way we do it is we actually bounce it over to another base somewhere. It may be states away, but we're all working off the same guidelines. There may be some differences according to the program, small differences here or there, but we're all working off the same body of guidelines. So we bounce that back and forth so you can get a good non-biased judgment of why did you do this, why did you do that? And then also pats on the back. Hey, you guys did a great job. Then from there, it goes to the base supervisor to look at. Base supervisor, according to what it is, may be able to close it. But if it's got any procedures in it, anything out of the ordinary, RSI, intubation, if it's low volume, high risk, OB, pediatrics, things like that, it automatically goes to one of the managers like myself and the medical director to look at. So you've got a lot of eyes looking at these cases, and so we're always saying, hey, good job here, why'd you do that? Good job here, why'd you do that? And then we typically pull out normally about 4 to 5 cases a week per region, and we actually get on a phone call with the crew, the medical director, everyone, and say, all right, walk us through this. Tell us about this case. And these are some of the sickest patients. We change processes over this. We change policies over this. We change what we carry, equipment we carry over these. Also, you'll have clinicians change practices over the feedback that they get during these calls. So that's something that we've added the last couple of years and doing a lot more of, and it works really good. And we've seen a lot of really positive changes off that, and it's great. We just went through CAMES just recently, and the amount of items that I had from those calls where we could take and show that we identified an issue and all the way into loop closure with a memo went out, a policy change that went out, a procedure change that went out. Maybe a clinician put on a performance improvement plan over something that we identified, a weakness we identified, or that it was a weakness we identified a couple of times. But to show that loop closure and show how we done that, it was great, and it was great to see back and say, hey, this process works. But I think that's very, very important. If you never have anyone, I know people, it's armchair quarterbacking. Who are you to tell me what I'm? You've got to have that process to keep you honest. There's a ton of autonomy in this field, but with autonomy comes responsibility, and part of the responsibility is being able to say, this is why I done what I did. And we expect every clinician to be able to say, this is why I did it.
Yeah, and that's a great point. Every company's different. I think when you look at Air Methods, for example, the guidelines or protocols are not looked at as protocols, or looked at as guidelines. And so you're really expected to be able to move through multiple guidelines on one patient. You may have a lot of gray areas, and you have to decipher those gray areas, and you have to make second decisions sometimes.
Yep.
And I think the process that you said where you pull 5 charts and you go through them, I think the important thing for the audience to know is that is not punitive. Obviously you have to answer for what you did and have backing. That's where a company like that you work for is I think amazing, that they really allow and encourage critical thinking, but at the same time you have to be able to answer for that critical thinking and those debriefs, as you call them. I think that's an amazing tool to change processes, like you said.
Yeah.
And I think it's real easy reactionary-wise from the crew standpoint of saying, why am I going to be on a conference call with 3 managers and a medical director? And you have to understand that it is not, you may have done everything perfect. Maybe they saw some stuff that they were like, wow, maybe they saw some stuff that wasn't real good.
Yeah.
But as long as you have transparency, you're going to grow as a person. The company's going to grow. The collective base is going to grow, and we all learn from that. And I think that's a hard thing you have to have that humility, and that's where it comes back to that hiring process that I found so positive. Is that truly is such an important thing. We get so enamored by experience and certs and what somebody's done, and you come in and you're a big a-hole and you're arrogant and you're sloppily dressed. To me, presentation, when somebody walks in, and I've said this before, if somebody walks in and they are dressed in a suit, or for a woman, they're in nice clothes, and they walk up and they shake your hand and they look you in the eye, man, I can't tell you how big of a first step for me that is.
Yeah.
Because that shows respect. It shows that they care about their appearance. If they care about their appearance, I'm automatically going to think that they care about their career and what they do,
Yeah.
So those things are huge.
Yeah, and that's something that we really look at a lot because, as you know, a lot of the areas in our region are very competitive. And in their competitive, they have choices. Customers have choices. And so when you show up and you're wearing a flight suit that says Air Methods, you are the biggest PR item there is out there. It is your professionalism, how you act, how you treat those nurses, medics, doctors, community. When you land at an elementary school and you're doing a PR to show the kids the helicopter, that's big.
Yeah.
And if you don't have that sense of, if we can't pick up that you're going to have that sense of professionalism, that's going to stand out to us, and that's going to be an issue during your interview process, and that's going to start you off, right off the bat of saying this might be an issue, and that's something we have to look at.
Yeah, so, I think to close this up, I think one of the things that I think is a strong aspect to somebody coming in, as we said, personality, humility, those things are huge. And I always, when I get emails from people, I have to be kind of generic in giving advice, but I say those exact things. If they ask you a question that you don't know, be upfront and immediately say, hey, I don't know that, but I'm really willing to learn that. That's just not something that I was put in situations with. I didn't ever use that medication, etc. And so I do give that advice. Obviously, if you come in and you're a 3-4 year or a 20 year, if you come in and you already have an RP, you already have an advanced trauma course, you come in and maybe you don't have your CFRN yet. Maybe you've taken a review class. If you've already started that process forward, to me, that's also a big deal.
Yeah.
That shows that you have initiative. It shows that you are truly, truly invested in this next step in your career. So I think from my perspective, that's a big step forward.
Yeah, and one more thing I would add is always research your local state regulations too. Some places, very few, but some require different things of nurses when they go into the ambulance in the pre-hospital. So I can tell you Michigan, I can tell you Tennessee will require you to be at least an EMT. So that's things to know if you're looking for this type of career.
Absolutely. All right. Well, is there any other high points you think we need to hit on, or do you think that's?
I think we covered the big ones. At any point, anyone can reach out to me. I'd be more than happy to give them some guidance. The last 5 years of hiring people, I've seen a lot of different ones. I've made some mistakes. I've hit some gold mines.
Yeah.
So I've learned a lot over 5 years of hiring and doing interviews. So I'll be more than happy to help anybody out I can.
Okay. Well, we will put his email in the show notes. And really appreciate your time, man. Good to see you. And
thanks, Eric. Great to see you.
Yeah. And for everybody, if you have any questions, email me again, eric.bauer@flightbridgeed.com. Kelly, his email is william.miller@airmethods.com. Again, I will put that in the show notes, and we will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.